Well, good evening, one and all, and welcome to the program on RXpertise, antimicrobial therapy, when and what to prescribe in bacterial respiratory tract infection. Let me just start off with a note of explanation from last week. There was unfortunately an internal issue, which is why the webinar did not occur. I was there and the support person was there as well. And by the time it was figured out, it was just too far into the program. So I really apologize for that, and that this will be available on recording. So with that in mind, let's get going. And I am Dr. Margaret Fitzgerald, founder of Fitzgerald Health Education Associates. My clinical practice has been in an FQHC in a small city about 30 miles north of Boston and the community of Lawrence, Massachusetts, where I have been privileged to be a full scope of practice primary care provider, OB, peds, young people, people in the middle, older people. It's a true family practice where I've had multiple 3-generation families, 4-generation families, and even 1 5-generation family in my practice. And while there, I was teaching the family practice physician residents. I've worked with medical students, countless NP students over the years. I also am on faculty at Case Western Reserve University, where I did my doctoral studies, sit on the editorial board of a couple of different publications, and I'm the only nurse practitioner to sit on the Pharmacy and Therapeutics Committee for a major HMO based out of Boston, Mass General Brigham Healthcare. And I always like to tell the newbies, because a good part of my world is helping NPs get ready for their boards. And I always love to tell the new folks this, and because this barely scratches the surface on the things I've been able to do as a nurse practitioner. And one reason I do that is so that they can conceptualize what they will be able to do with the role. So disclosures: no real or potential conflict of interest to disclose. No experimental investigational use of drugs or devices will be presented. And if I do talk anything off-label, I will identify as such. So the objectives: identify factors influencing the choice of an antimicrobial, with special emphasis on recognizing patterns of causative pathogens in bacterial infection. Describe the influence of antimicrobial resistance and the antibiogram in the choice of a therapeutic agent. And then recognize clinical scenarios where antimicrobial therapy is not routinely indicated, but often prescribed. And references will be throughout and at the end of the presentation. So a key concept to clinical practice is understanding the importance of antimicrobial stewardship. And I know from the work that I've been able to do with NP students is antimicrobial therapy is one of their gigantic pain points, because very often, particularly people who have not done so well on boards, will say to me, I got a question on having an antimicrobial for fill in the blank, whatever it is. There were 4 antibiotics listed. I've seen all 4 prescribed for that condition. How am I supposed to know what to prescribe? And by the way, our next session together, I'll be covering UTIs and skin and soft tissue infections. So a little bit different group of antibiotics. And that is the idea of prescribing antimicrobials is very confusing, I find, for NP students and newer clinicians. And now we add in, hey, you better be a good steward of prescribing the antimicrobials, and things get even more confusing. So this gets into the overuse of antibiotics in the United States. Antibiotics are prescribed in about 10% of all primary care visits, and that's more than 250 million courses of antibiotics prescribed every single year. Please remember, there are only about 330 million people in this country, which means at this point, I fully appreciate some people get multiple courses of antibiotics, but that's really getting up there that it sounds like the majority of us have had an antibiotic in the past year. At least 30% of prescriptions are considered to be either unnecessary or there's something else wrong with the prescription. And one of the most common parts is too long a prescribing period. And we have to keep that in mind. And the potential effects of antibiotic overuse and underdosing is development of resistance. So here's another way of thinking of it. Every time, when I was saying too long a course of therapy, big contributor to of antimicrobial resistance. But when you think about it, every single dose of an antibiotic prescribed in a viral illness was too long a course of therapy. Every single dose was unnecessary. And what that does, plus even when people would be in a situation of benefiting antibiotic, if the antibiotic is underdosed, all of that contributes to the development of resistance. So, all right, so let's take the case where we've got somebody who clearly has a viral infection. And let's say they're on day 2 of a viral URI, green nasal discharge. The person comes in and says, I think I'm getting a sinus infection. And the prescriber gives them azithromycin, the proverbial Z-Pak, and sends them along the way. I understand that because what's one of the fastest ways of moving somebody through an exam room? In urgent care. And my practice in the primary care where I've been has been about 40-ish% urgent care, about 60% primary care. But our urgent care is only for people who are patients of the clinic, but lots and lots and lots of same-day urgent care visits. So I know it takes a lot more time to describe to the patient viral illness. Antibiotic won't be of help, but I can tell you feel really poorly. I'm kind of riffing here on what I'd say to the patient. I wouldn't speak kind of so casually or so quickly to the patient. Let me give you some advice on things that can help you feel a little better. How about a note from work? What can I do for you today? And remember, the good news is today your body's doing a really good job fighting off this viral infection and you don't need an antibiotic. That's really good news. Okay, that takes time. We all know that. One of the quickest ways to move somebody through is to say, yes, day 2 of a cold, you've got a little green nasal discharge. Here's your azithromycin prescription. Next. Yeah. And that is why in the approximately 25 years since azithromycin landed on the US market, it is useless or almost useless for Streptococcus pneumoniae infection now. Almost useless. It is one of the contributing factors to the fact that chlamydia trachomatis no longer is treated first line with azithromycin. It is the reason that that antibiotic has fallen way down on the decision-making tree for when you believe a person has an atypical pathogen pneumonia. I mean, I could go on for the rest of the night on what azithromycin no longer works in, and this is one reason why. So what's antimicrobial stewardship according to the CDC? It's the effort to measure and improve how antibiotics are prescribed by clinicians and used by patients. Improving antibiotic prescribing and use is critical to effectively treat infections, protect patients from harms caused by unnecessary antibiotic use, and combat antibiotic resistance. Now, this is something that I often share with newer NPs when I'm teaching them, particularly in NP review, is to remind them above and beyond everything with antibiotics, what do we know is a major risk factor for the development of C. diff disease? Okay. And A lot of times they'll say, oh, but that's in the hospital or the nursing home. No, 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 no. C. diff exists out in the community. Usually the people are a lot less sick with it than they are in the hospital, because in the hospital, they were sick enough to land in the hospital. So there's all those confounding variables. But here's the thing. The last person who I saw with C. diff in the office was an otherwise healthy teenager who had been given a course of amoxicillin when this teen had a cold. It was not even a course of a needed antibiotic. A provider, I saw the note. Provider coded the visit. It was not somebody within the clinic where I practice. It was from an outside source. The provider coded the visit as viral URI on about day 3. I'm sure the kid felt rotten. Gave the kid a week's worth of amoxicillin, subsequently developed C. diff, and was hospitalized for weeks. Very, very ill. So you don't want to be prescribing antibiotics when they're not needed. If the child had needed the antibiotic and developed C. diff, that's very unfortunate, but at least there was a therapeutic need for it. So let's get down to this. The first question to ask when applying principles of empiric antimicrobial therapy: do you have any evidence that the antimicrobial therapy is beneficial in the treatment of this condition? And that gets us to the number needed to treat, the NNT, which is a measurement of the impact of medicine or therapy by estimating the number of patients that need to be treated in order to have impact on one person. So an NNT of 1 would be everybody who gets that therapy gets better from that therapy. Nothing has an NNT of 1. Nothing does. And so what's assumed with NNT? That some people will get better with all therapies. Some people will be unaffected. Some people will be harmed. And the NNT gives us an idea of how many each. As a rule, NNT for a symptomatic condition should be less than what number for the therapy to be considered acceptable? Would it be an NNT of 2? In other words, 2 people treated, 1 benefits. An NNT of 5 people treated, 1 really benefits. An NNT of 8 or an NNT of 11. And the general rule is an NNT of 5 before. So 5 less is the way you want to be looking at this. So a meta-analysis of antimicrobial therapy versus placebo in ABRS, acute bacterial rhinosinusitis. The number needed to treat in adults was 13. The range, because of course this was a meta-analysis, was 9 to 22. In children, it was 5. So it was right on the cusp with a range of 4 to 15. Now, one of the things I want to remind you, kids don't develop their sinuses well until they're beyond toddlerhood. And even they really have to be like in grade school before they have sinuses. So that 2-year-olds with the big boogery green booger nose, that just the stuff is pouring out of their nose, actually doesn't have a bacterial sinusitis because there are no sinuses to infect. So then the question comes up, well, why would anybody any age have green nasal discharge? It is due to the infiltration of white blood cells into the nasal cavities, the sinuses, and that type of thing. That's what actually stains the nasal discharge green or yellow or maybe even white, but more like what catches people's attention. It's the yellow and the green nasal discharge, right? And they assume it's bacterial infection. It's probably more white blood cell invasion. And I will even say to patients is like, particularly parents who are very concerned about their little one running around with the big nasal discharge, but the ears look okay, maybe a little bit of fluid behind the TMs, throat looks a little red, but the child's coughing. The child clearly has some kind of viral respiratory tract infection. And they'll say, yeah, but what about that green stuff coming out of his nose? And what I will say is, I'm really encouraged to see that. That means that your little one's immune system is fighting this off beautifully. One more time, the good news is your baby doesn't need an antibiotic. And that falls on ears, regardless of people's age, much better than I could prescribe an antibiotic, but I'm not going to because it's just a virus. I never ever say to somebody that it's just a virus because so is Ebola, so is HIV, so is FYI COVID-19 that has killed something like 1.25 million people in this country. And I might even be a little behind on those numbers and still kills people every single day. There are lots of viruses that we don't want to get, All right. So what about teaching antimicrobial therapy? How should you do it? Disease state, drug class, by clusters of likely pathogens. Here is something that when you're thinking of what the students are doing for organization of their knowledge, NP students often struggle with learning the principles of pharmacology therapy, in part not doing to making connections. By the way, that is my observation, okay? And however, it's borne up in some research about learning. So antimicrobial therapy, 3 major bacterial organisms cause acute bacterial rhinosinusitis, acute otitis media, and COPD exacerbation when COPD exacerbation is caused by bacteria. They need to recognize the similar antibiotics used. And as I'm teaching that in NP review, and what I have to do is give all credit to you folks, all credits to you folks, because you've, shall we say, primed the pump. And I've really caught their attention now teaching review because they're like, oh, yeah. We're getting like the gigantic final exam, the NP board's coming up. So I really have caught their attention with teaching review. But once I point out to them these different things, by the time we get to COPD exacerbation, they go like, oh, okay, now I know. Now I know why these antibiotics come up. By the way, last week I taught an NP review course online, live stream. I had about 75 people in it, and I answered over the course of the second day of the course alone 132 questions, which I was delighted because they were so engaged. And only a couple of the questions were frightening. Would be happy to know that. All right. So what are these bugs? So, and by the way, I didn't put it here, but it's also acute otitis media, ABRS and COPD. Remember, COPD only when it's caused by bacterial, COPD exacerbation when caused by bacteria. But acute bacterial rhinosinusitis, COPD exacerbation when it's bacterial, Streptococcus pneumoniae, gram-positive diplococci, most common cause of fatal community-acquired pneumonia, most common cause of ABRS and acute otitis media when the person's pretty sick with it. Haemophilus influenzae, a gram-negative organism that produces beta-lactamase. So just a reminder, what that does is the beta-lactamase goes to the beta-lactam ring, and the penicillin, amoxicillin, ampicillin molecule cleaves it. The penicillin, amoxicillin, ampicillin won't work. About 30% of the isolates produce beta-lactamase, and then Moraxella catarrhalis, which is way the proverbial distant third in this top 3 here. And Moraxella catarrhalis, another gram-neg. You might as well assume all the isolates produce beta-lactamase because it's like 90 whatever percent of them produce beta-lactamase, okay? Now, what did we already go over? ABRS, number needed to treat, was super high in adults, right? So what does that mean? That means even when a person meets diagnostic criteria for acute bacterial rhinosinusitis. So remember, we're doing empiric antimicrobial therapy. Even when they meet diagnostic criteria for ABRS, like URI-like symptoms persisting more than 10 days, double sickening, they get better with their cold-like symptoms, and then they get worse over the course of like a week or so. Regardless, they truly do meet diagnostic criteria for that. What that NNT means is, even if it was bacterial infection, the vast majority will get better whether you give them an antibiotic or not. In other words, their immune system will take care of the infection. I'm not going to hit the acute otitis media guidelines because later in this series, I'm doing a PED session, and I'll talk about it then. And the reason for that is that when we're really talking about acute otitis media and antibiotic therapy, we really are talking more about the little squirts rather than the adults, even though adults can occasionally get AOM. But one of the key points to keep in mind here then is if it is ABRS and you don't treat, they're going to get better anyway. The immune system will take care of it. For those of you who are familiar with the AOM guidelines for kids, you will notice, and again, we'll go into this in more detail in a upcoming program, is that there is that watch and wait that's advocated by the American Academy of Pediatrics that says, give the kid who's really not that sick with acute otitis media, if the parents and caregivers are willing to do this, give them a few days, see if they clear up, because a lot of times they will. A lot of times they will clear up, right? So what are the commonly recommended antimicrobials for ABRS and COPD exacerbation? Amoxicillin, amox with clav, doxy, and the respiratory fluoroquinolones. Okay, those are generally considered to be some of the first line drugs. Okay, and so why? Because they're caused by the same bugs, and these are active against the aforementioned organisms. Now, I do want to make mention, I really can't in good spirit go beyond this slide without saying a couple of things. One is, remember, with COPD, only about 40% of the exacerbations have significant bacterial contribution. If we were talking 10, 15 years ago, we would have said, oh, most of them are bacterial. That was then. This is now. Now we know better. Only about 40% have bacterial contribution. And again, with the ABRS, gets better a lot quicker, but without an antibiotic. But the respiratory fluoroquinolones for these conditions, both of them, never, ever, ever are the respiratory fluoroquinolones first line. Ever, 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 ever. And one of the reasons is there was an advisory that came from the FDA maybe about 5 years ago, very, very strongly worded, saying, don't go with the fluoroquinolones first line for like UTIs, ABRS, things along those lines, even COPD exacerbations, when you can use another medicine. And the rationale behind that is the adverse effects that go along with the respiratory fluoroquinolones, tendon rupture, some cognitive issues, particularly in older adults. And on top of that, the risk of developing pathogens that are resistant to the respiratory fluoroquinolones or even ciprofloxacin, because what we want to do is have those as almost like on the shelf to use in emergency, but not use them day to day. All right, this is something I hear. I'm looking at prescribing information for amoxicillin. Total daily dose range for an adult is 750 milligrams to 4 grams. Well, that is quite the range, isn't it? Yes. Now, this is a good teaching principle. Why are we talking for an adult? Let's pretend it's a regular sized adult. So we generally don't increase antibiotic doses for obesity, generally oral outpatient therapy. Sometimes we do, but the 750 to 4 grams a day. That is more than a fourfold increase from the lowest to the highest, right? Okay. That's a good example of what's called a wide therapeutic index drug, WTI, wide therapeutic index. A little bit might be enough. A bucket of it might also be safe. You just don't know. So how do I know what to prescribe? So what determines the dose of an antibiotic? And the pharmacologic absorption and distribution of the antibiotic will influence the dose, route, and frequency of administration of the antibiotic in order to achieve an effective dose at the site of infection. Going a little off script here for after I just pontificated about not using a fluoroquinolone first line, but this is a really good example. For a simple lower UTI cystitis, 250 milligrams of ciprofloxacin BID, fine and dandy. Oh, pyelonephritis, when you want to concentrate the antibiotic in the renal pelvis, 500 milligrams. So in other words, like the urinary tract is a fairly easy place to concentrate an antibiotic. Interestingly, the sinuses, it's not that easy to concentrate an antibiotic there. The middle ear, not that easy to concentrate an antibiotic there. And that's one reason why, particularly when we're looking at kids with otitis media or ABRS, sometimes the dose of antibiotic we're giving them looks really frightening. But that's part of it is the amount you need to get into that more closed space. Now, here is something else to consider is with antibiotics, how often do you need to use them? Some antibiotics are time dependent. Some are concentration dependent killers. Most are concentration dependent killers. So the idea with a concentration dependent killer is you need a fat dose just a couple of times a day to do it. And I'll always joke with people when I'm teaching pharmacology, particularly the newbies. If I see you prescribe 250 milligrams TID of amoxicillin for an adult with an acute otitis media, I will find where you live and sit in your front lawn until you explain it to me, because it just isn't enough of the antibiotic to really do anything. Now, 875 milligrams BID, now we're talking in the adult. Now we're talking, that's going to be enough. It's less frequent and it's a much, much higher dose, okay? So how are the doses of antibiotics developed? And part of this is a concept of minimum inhibitory concentration. And this is the lowest concentration of an antimicrobial that will inhibit visible growth of a microorganism after overnight incubation using standard conditions. When you read that the dose of a given antibiotic, and this is an antibiotic I'm making up, 500 milligrams BID for an adult. That means at 500 milligrams BID, it's 2 to 4 times MIC. So why not just have the dose be at 1 MIC? The reason for that is the overkill will allow for variations in absorption and distribution, and recommended antimicrobial doses are reflective of anticipated MICs. So here is an example from Infectious Disease Society of America on ABRS in the adult. Okay, amoxicillin, you could do 500 TID or 875 BID. I think you already got my bias on that one. Yeah, I like the 875 BID. when to use when somebody's had no recent systemic antibiotic use, and why that? Because that means they're at lower risk for drug-resistant strep pneumo. Mild to moderate signs and symptoms, no comorbidity, and lower community rate of drug-resistant strep pneumo. I'll give you an idea of how you find that out in just a moment. Now, Amox 1 gram TID or Amox with clav, 2,000 milligrams of amoxicillin, 125 of clavulanate. The clavulanate inhibits beta-lactamase, so the amoxicillin can take care of the beta-lactamase producing organisms. That's an extended release BID formulation, happens to be, that's brand name Augmentin. When to use? When you have recent systemic antibiotic use within the past month, because any systemic antibiotic use alters the body's microbiome. And about 70% of adults are walking around with strep pneumo in the oropharynx at any given time. Age greater than 65, daycare exposure. Daycare exposure is an interesting one. The source of drug-resistant strep pneumo in our community comes from children in large group daycare. It is, which is defined as more than 10 kids in one place at a time. It's not an escapee from the ICU or the long-term care facility. It is not. High community rate of DRSP, severe signs and symptoms, including higher fever, that you hardly ever see with ABRS, and select comorbidity like diabetes and immunocompromise. And I always have to say, when I'm talking about the quote diabetes part, here's something to keep in mind with the diabetes part is the following. That with diabetes, it makes a huge difference with glucose control. If somebody has an A1C of 11, they do much poorer than somebody whose A1C is 6.8. Makes sense. All right. So here's the antibiogram. This should be full page, the last page of your handout, because otherwise your eyeballs are going to be stressed on this one. And so the antibiogram, you could see that, by the way, this is available from your local Department of Public Health, or if you're part of a larger healthcare system, generally your Pharmacy and Therapeutics Committee will provide this for you. And it's typically updated on an annual basis. So if you look across the top, you'll see where it says gram-positive organisms. We're going to take a look at strep pneumo, which is way over to the right of the gram-pos, and then it flips to gram-negs. And what you're going to see, it's the second to the last on the right. And you'll see that they only tested 15 isolates, and then you'll notice underneath it, the number 80. And then if you go over, you'll see 80, and then you'll see penicillin. This means in this community, 80% of the isolates of strep pneumo are sensitive to penicillin, which then means ampicillin, amoxicillin. Okay. It means penicillin, ampicillin, amoxicillin. And that also means then they've got a 20% drug-resistant strep pneumo rate, right? Now let's go down the strep pneumo column there. And you'll notice that when you get to ceftriaxone, 93% of the isolates are sensitive. So ceftriaxone, wonderful drug. I always marvel at ceftriaxone because it's been around now 35 years, probably close to 40 years, and it still works remarkably well on a lot of different things. Like, in other words, we haven't worn it out yet. We haven't. It's really quite amazing. But you'll also recall ceftriaxone is injectable only, IV PO. Bear with me. I'm a family NP. I'm an outpatient provider. Most of the people we're teaching will be, in fact, outpatient providers. We know that. So we want to do oral meds as much as possible. So am I saying, so go ahead and use ceftriaxone? I am for outpatients. On occasion, we have to do that. But what that means is all the second and third generation cephalosporins will have those same qualities. So this is a community where a second or third generation cephalosporin will do the job on strep pneumo. Now, I want you to go down a little bit more. Vanco, 100%. That's kind of, I'm not going to say it's national, but it's pretty common. But Vanco is a pain in the neck to use. But then I will also, just going down on the strep pneumo, erythromycin, only 23% of the isolates are sensitive. So if only 23% of the isolates are sensitive, that means only 23% of the isolates of azithromycin, clarithromycin, and erythromycin, all the macrolides are sensitive. So in other words, a Z-Pak would be a perfectly horrible, horrible drug to use for somebody with ABRS, because we know the leading drug is going to be, the leading bug is going to be strep pneumo. And then when we go down there, levofloxacin, 86%, and Bactrim, about 71% of the isolates are sensitive. So that's how you utilize a antibiogram. Now I'm going to make one other point here. We're going to go over to the right and look at Haemophilus influenzae. It's about 3/4 of the way down the page. They only tested 9 isolates, but 78% of the isolates were sensitive to penicillin. That means in this community, only about 22% of the isolates of H. flu produce beta-lactamase. Only about 22%. National average is around 30%. Some places in the country, it's a little higher at 40%. Okay? So that's how you utilize an antibiogram. And invasive pneumococcal disease like meningitis, septicemia, bacteremic pneumonia, the proportion of invasive pneumococcal disease not susceptible to antibiotics. This is a little bit older study and ended in 2021, in part because they said, we have to really stop observing this and pay attention to COVID-19. But what you will notice is that penicillin, the proportion of isolates not susceptible to penicillins actually has gone down a little bit, but the proportion resistant to erythromycin, i.e. azithromycin, has gone up significantly over time. So what about pneumococcal conjugate vaccine? This would be products like Prevnar. There's also the PCV21 is a different trade name, which escapes me right now. But we've had this now, the pneumococcal conjugate vaccine, for 25 years now, because it first came out for the kids in 2020. And you could see as time went on, we started adding it more and more to the kids, more and more to the adults, and that type of thing. And I will say right now, the pneumococcal vaccine schedule for adults is mind-blowing, to the point that the CDC actually developed an online calculator at their website where they'll tell you what people need. It's wonderful, wonderful. So antibiotic, and by the way, just the reason I brought up pneumococcal vaccine is the more people we have immunized with pneumococcal disease, the less of the invasive or life-threatening pneumococcal disease that we see. So true or false, antibiotic underdosing is one of the most common reasons for antimicrobial treatment failure, likely more common than resistant pathogens. And that's true. And remember, most of our students are coming from the acute care area where they're hearing resistant bugs, resistant bugs, resistant bugs. And they have to realize if they're now practicing more in the outpatient setting, they're going to see a lot less resistant bugs. And even in the inpatient setting, there's a reason why one of the first line antibiotic combos for community-acquired pneumonia is ceftriaxone and IV azithromycin. The azithromycin is there to take care of M. pneumoniae and C. pneumoniae, but not the strep pneumo, okay? And pneumococcal conjugate vaccines have reduced pneumococcal infections caused by vaccine serotypes, most of which were resistant to antibiotic caused by vaccine serotypes, have decreased by 90% in kids and 60% in adults. And that's also true, another public health triumph. You know what I'm going to do right now? I'm going to leave it there on the state of us getting people immunized. I just have to leave it there, or that's a whole other discussion. Okay, let's take a look at the Gold COPD guidelines. Gold COPD, by the way, open access. They've got a wonderful app. We all love apps, right? But a really, really, it's all downloadable. I love referring people to that because they learn so many nuances of caring for people with COPD. And I do want to say the comments on the slides on COPD exacerbation are really limited to antimicrobial use or not. This is not meant to be a comprehensive review of this topic. So define COPD exacerbation. It's an event characterized by dyspnea and or cough and sputum that worsens over about a period of less than 14 days. And one of the things I want to remind you is if you've got a patient with COPD who develops pneumonia, they are also having a COPD exacerbation. Please, I just went through this with a family member. I was like, really? No, he's having a COPD. It's a sibling who's quite ill. And with the pneumonia, I was like, yeah, he's also having a COPD exacerbation. You need to address that as well. So aside from bacterial infection, tobacco use, air pollution, and respiratory tract viruses are common contributing factors to COPD exacerbation. True or false? And that's true. And remember, you have our permission. If you like any of these learning exercises with your students, please use those. So what causes then the exacerbations? It's something that is causing a local or systemic inflammation of the airway by infection, can be bacterial, but only about 40%. Viral respiratory tract infection is the most common reason for a COPD exacerbation, but it can also be rather than just like regular old run-of-the-mill cold viruses, can be RSV and of course COVID-19, pollution or other insults to the lungs, and then less commonly by the bacterial organisms. We've gone over these before. So what would be the treatment of COPD? You add a bronchodilator, a SABA and or a SAMA PRN, add a LABA or a LAMA and or an ICS if the patient's not already using one. In other words, you want a long-acting bronchodilator on board. Systemic corticosteroids to shorten recovery time, minimize hypoxemia and relapse risk. I cannot say this strongly enough. Prednisone, prednisone, prednisone. 40 milligrams PO for 5 days. And then antimicrobial therapy, big maybe on that one, okay? And so if the baseline FEV1 is less than 50% of predicted with severe or very severe COPD, so you add that systemic corticosteroid, the prednisone, very similar to what you would do with, or one of the options for an asthma flare. Is there a benefit of PO or injectable? Is one superior to the other? And the answer is no benefit of injectable versus oral if the gut works. But corticosteroids can, as the drug, okay, it goes in the IM injection. There's obviously a track left where the corticosteroid could leak back up the track from the needle, of course, and that can lead to permanent subcutaneous tissue atrophy that clinicians have been successfully sued for an unacceptable cosmetic effect with that. Plus, here's the other thing. Once a corticosteroid is in there injected, if the person has an adverse reaction, you can't discontinue it. It is in there for the duration. So no benefit of injectable versus oral if the gut works. And if the gut doesn't work, then this is somebody with a COPD exacerbation who belongs in the hospital. Is a taper needed? No, because shorter duration, lower dose you don't need to taper because the adrenals haven't gotten that sleepy, nor do you think the reason that you're giving the corticosteroid is coming back. Now, little fun fact, our body makes the equivalent of 5 milligrams of prednisone a day. People tend to be like that. So yes, 40 milligrams is 8 times what our body normally makes, but our body is making a prednisone equivalent every single day. So with the antimicrobial COPD exacerbation outpatient setting, you want to consider the potential risk versus benefit ratio with each antimicrobial. One more time, I think I've made my case. The systemic corticosteroid should be there. We've been over the bugs before. What are the less typical bugs? Atypicals like M. pneumoniae, C. pneumoniae, and other less common gram-positive and gram-negative organisms. You know what? I will tell you one thing. If you've got a patient who's been intubated, ventilated a few times with COPD, they've been in the ICU many times, they can grow out some pretty exotic bugs. But what a lot of us are doing is trying to keep people out of the ICU in the first place, so they never get to pick up those hospital bugs. So this is what I find to be an incredibly helpful little exercise. It's just a matching one. Again, just give us attribution and use with your students. Avoid use of one of these antibiotics with ACE inhibitor or ARB use due to hyperkalemia risk, particularly with CKD. In other words, which one of these antibiotics, amox, trimethoprim sulfamethoxazole, azithromycin, cefpodoxime, or moxifloxacin could cause hyperkalemia? Which one is it? And it's actually Bactrim. It's Bactrim. And the reason for that is the trimethoprim part has the ability to hold back potassium offload. Now, a 40-year-old with a GFR in the 90s, who's even on an ACE inhibitor or an ARB, I wouldn't lose a wink of sleep over them getting hyperkalemic on Bactrim. Not one. But an 80-year-old with stage 3B CKD who's a little dry because of whatever they're sick from, and they're on an ACE inhibitor or an ARB, that's the person I'm worried about. So, it's a good kind of general rule. Don't give Bactrim to old people. Plus, even with younger people, it's losing its muscle. There just isn't that much it will cover. Vulnerable to destruction by beta-lactamase. That, of course, is going to be amoxicillin. QT prolongation risk. And again, I'm not so worried about the 22-year-old with a structurally normal heart, but the 75-year-old with some occult cardiovascular disease, who's got COPD. Yeah, I don't want that person's QT to get longer because of the Torsades risk or the VTAC risk. And that would be azithromycin. And that is what's called a class effect. It's for all the macrolide antibiotics. So it's azithromycin, clarithromycin, erythromycin. Associated with tendon rupture risk, particularly with a systemic corticosteroid. And your folks with COPD exacerbation, you're going to be giving virtually all of them a steroid. What would that be? And that's going to be moxifloxacin. The tendon rupture risk is like 64-fold higher than baseline. And less than 1% cross risk in penicillin allergy. Obviously, we only have one left. That's cefpodoxime. Okay. And antimicrobials. If you're going to use one, you want to consider, and we're being advised here, mild to moderate COPD exacerbation. Don't bother with the antibiotic. Give them something to calm down their airways, and that is the prednisone. And if I have patients who say to me, yeah, but what's going to get rid of the phlegm? If I don't get an antibiotic, I'll say, the phlegm is being caused by the tissue swelling from whatever's causing this. The prednisone is going to do a great job on that within a day or two. You're going to notice a huge difference. So amoxicillin, It's going to be a problem if it's H. flu or MCAT that produces beta-lactamase. Trimethoprim sulfamethoxazole, you're going to have at least a 1 in 4 treatment failure risk. Plus, remember what I just said 2 seconds ago? Doxycycline, one of my faves. Effective against non-resistant strep pneumo, which is the majority of isolates. Pertinent gram-negs, stable in the presence of beta-lactamase because it does not have a beta-lactam ring. Does not, okay? And even in severe COPD, the role of antimicrobial therapy is debated, but one more time, they throw this little bit in there. You consider the severity of COPD and comorbidities in the decision-making process. So these are the things that you should consider. From the beta-lactams, amox with clav, that's going to take care of H. flu, MCAT, and strep pneumo if you give enough of the amoxicillin. Why will it take care of the H. flu and the MCAT even if they produce beta-lactamase? Because of the beta-lactamase inhibition with the clavulanate. But I could not, in good faith, give some poor soul having a COPD exacerbation amox with clav. It'll work. The clavulanate's so tough on the stomach, particularly if they're not eating well. Whenever I prescribe amox with clav to somebody like with a sinus infection, I'll say, you need food in your stomach, not a cracker and a sip of milk. You need piece of toast with some peanut butter on it. You need some fat. You need some bread and cheese, something that's going to sit there for a while. Most people with COPD exacerbation, they're eating like little tiny birds if they're eating at all. A cephalosporin. Now, this is a good kind of in your back pocket drug to think of. I think one of the reasons why it's not more forward in a lot of guidelines is these were horrifically overutilized like in the 1980s into the early 1990s. And then they have really fallen off in how much they've been used. But this would be a second or third generation. As you go up the generations, the gram-negative coverage gets better. Cefdinir, cefpodoxime, very well tolerated, easy on the stomach, 0.0 drug-drug interaction potential. We're talking about COPD exacerbation. Most people are on a myriad of drugs. Now, the macrolides. I'm really quite surprised this is even on the list because with azithromycin and clarithromycin, you've got that QT prolongation potential, poor strep pneumo coverage. Cover the H. flu and the MCAT, no getting around that. A clarithromycin is also a cytochrome P453A4 inhibitor. It's going to interact with 50% of all prescription drugs. Now, the respiratory fluoroquinolone, it's specific moxie and levofloxacin. The tendon rupture risk, there is a QT prolongation potential, less than with the macrolide. But this is the one you might want to think of. Backs against the wall. You're trying to keep somebody out of the hospital. They took another antibiotic 3 weeks ago, whatever it would be, and you think you might have drug-resistant strep pneumo. That's where the respiratory fluoroquinolones tend to shine, okay? So, well, I think I said 64. I reverse numbers. And true or false, patients prescribed both fluoroquinolones and systemic corticosteroids have its 46-fold greater risk of Achilles tendon rupture than those taking neither med, and the answer there is true. All right, 2 most common tendons to rupture with fluoroquinolone, the tendon at the base of the thumb, I don't remember the name of it, and the Achilles tendon. And in one study, one observational study, it was actually like 90% were, it was the Achilles tendon. All right, so let's wrap up here and talk about acute bronchitis. And remember, this is a clinical diagnosis characterized by lower airway inflammation, usually presenting with cough, with or without sputum production, absence of fever, and tachypnea lasting for greater than 5 days, typically following a URI. It's noted only in the absence of asthma, COPD, or other airway disease. And, I like to reinforce this when I'm talking to folks. It's not asthma with acute bronchitis. No, it's an asthma flare. It's not COPD with acute bronchitis. No, it's a COPD exacerbation. So true or false? The diagnosis of acute bronchitis is usually limited to those without airway disease, so no asthma or COPD. And that, of course, is true. Which of the following is the most common pathogen implicated in acute bronchitis? Is it A, strep pneumo, B, H flu, C, M pneumoniae, the most common of the atypical pathogens, or D, respiratory virus? And the correct answer, of course, is D, respiratory virus. And how common? Greater than 95% of the respiratory viruses. Greater than 95% of the time, excuse me, acute bronchitis is caused by a respiratory virus. Greater than 3/4 will resolve in 2 weeks without any treatment. And for protracted problematic cough, you can try an inhaled bronchodilator, such as a SAMA, like ipratropium bromide or Atrovent. I got to tell you, that's the one that really works. Hard to get insurer to pay for it without a COPD diagnosis, or a SABA, short-acting beta-2 agonist like albuterol, or if you're really trying to go on the cheap, 3 to 5 days worth of prednisone, 40 milligrams daily. Okay, and you might say, whoa, that seems like overkill for a person with acute bronchitis. Yeah, I would agree with you on that one. It's $4. It's a lot of times I just do prescribe 3 days of it. It gets rid of the cough in like 48 hours. It really does. It's like turning off a light switch. And so that's something you could consider the steroid, but only after more common causes of cough, including rhinosinusitis, asthma, or gastroesophageal reflux disease have been ruled out. You know what? I think my screen stopped sharing for some reason. Okay. Stephanie, can you check on your end and see, because on my end it looks like I'm sharing. Let me just try one more thing. I'm going to stop the share. Okay, and then I'm going to
Okay.
share again. Okay, because all of a sudden I just got this signal that it had been paused. Okay, I think I'm back. I'm back in action again. So only consider the steroid though, unless you can figure out another reason why the poor soul is still coughing. All right. So bacterial pathogens less than 5% with acute bronchitis. And it's most likely to be M. pneumoniae on the rare occasion, rare occasion that you're thinking about prescribing an antibiotic. Make sure it is a macrolide or doxy, because penicillin or a beta-lactam doesn't work on this one. So differentiation, this is a good drill to do with your students, is of pneumonia versus bronchitis. Pneumonia is unlikely if all of the following are absent. Please note the word absent. Fever, true. Tachypnea, true. Tachycardia, true. Evidence of consolidation on chest exam, true. So in other words, everybody with pneumonia also has bronchitis, but people with bronchitis, acute bronchitis, typically have no fever, no tachypnea, no tachycardia, and definitely no crackles on chest exam. Okay. So with antimicrobials, let's prescribe when needed, know the bug first, right med, right dose, right length of time, and please hold off when necessary. So let me see if any questions have come in. So would you ever consider extending the prednisone in COPD chronic bronchitis that doesn't seem to be getting better even with inhalers? Generally, if you go in there with the high enough dose of the prednisone, like the 40 milligrams for 5 days, that's typically enough. Typically enough. For all my pontificating about not using an antibiotic, sometimes what you might do is, in that case, consider an antibiotic when a person is not getting better with the prednisone alone. And what it is, you say, even with inhalers, make sure the person is appropriately using their controller inhalers. So like with COPD, since that's what we were talking about, really and truly, it's very hard to make the argument these days about treating COPD without having a patient on a LAMA/LABA inhaler. LAMA, long-acting muscarinic antagonist, like a tiotropium bromide Spiriva. LABA, a long-acting beta-2 agonist like salmeterol or formoterol. And, there are about a bazillion on the market now that have those two meds in one inhaler. And so that's super, super, super helpful. I think that was the only question that came in. Let me just double check up here. We don't have any in the Q&A. So again, I want to thank you so much for joining me this evening. I want to thank Stephanie for keeping us on track here. Stephanie, take a look in the chat box, make sure I didn't miss any questions.
It looks like you got them. The last one you covered when it asked about considering extending the prednisone in a
Yep.
COPD
Yeah.
bronchitis. So yeah, that's
Okay. Very good.
didn't-
Okay.
okay.
Thank you so much for joining us tonight. Wish you well. See you, and not too much more time when we'll be going over UTIs and skin and soft tissue infections and extending some of these principles that I talked about tonight. And thank you, Stephanie. Good night, all.
You're welcome. Good night.